having a session on symptom control. It will be taken by Dr. Sunitha Daniel. It will be co-facilitated by Dr. Rajashree too. Over to Dr. Rajashree.
Good afternoon, my dear friends. Very happy to see you all here on the second day of our webinar series on PalliCovid ECHO-11. So, to begin with, we have seen how COVID-19 has affected the whole world like a tsunami. It has gone beyond a medical issue much before. It has touched and probably wiped off many of the human domains. And palliative care has got a true relevance in the management of COVID-19, not only in terms of treatment per se, but it offers a holistic care by encompassing physical, psychosocial, and spiritual care and support. Am I audible?
Yes, Doctor, you are.
And yesterday, Moira had described how palliative care has been important in the context of COVID-19 and how it has helped millions of people suffering, needlessly suffering because of the pandemic. And she also emphasized what are the medical laws, but ethical principles governing decision-making in every challenging clinical situation. And it need not be culture-based, but definitely it has got culture and context orientation. Having said that, she also reiterated the importance of triage in the management of COVID-19, because all patients need not be managed alone. Alike. See, symptom management in milder, patients with COVID-19 symptoms, having mild symptoms, they can be very well managed at home. Whereas patients with moderate symptom need hospital admission and appropriate management. Patients with lots of comorbidities and having serious illness progressing to acute respiratory or adult respiratory distress syndrome, we have to have a decision-making role, whether they need to be subjected to futile interventions or not. So triaging carries an important role, not only in the management pattern, but also in alleviating the needless and endless suffering which is caused by unnecessary interventions. So with those principles in mind, we are moving on to the second day of the webinar series, where we are going to discuss symptom management. Symptom management has got a very important role in every respect. There is no exception. It is an exception case of COVID-19 as well. So let us see what are the major symptoms and how it can be effectively managed, not only effectively managed, but also or looking at all aspects of human suffering. So today we have a very distinguished faculty, Dr. Sunitha Daniel. She has got her postgraduate degree in medicine, palliative medicine, and she is the dedicated person behind the toolkit which we are. So today we'll be discussing about the symptom management in COVID-19. So over to you, Sunitha. And before she says, welcome all of you and fill our chat box with your suggestions and comments, because those comments and suggestions will help us moving forward. So let us have a very fruitful session. Over to you, Sunitha. Thank you.
Thank you, Raji ma'am. And thank you to Pallium India. Welcome to you all, and I'm so happy to see you all here today. And thank you for taking time from your routine session to, come and attend this session. It just shows that you also feel that probably palliative care is important in the context of COVID-19. Now, before I start, I would like you all to think about the session from yesterday, just to go through it in your mind. Think about Ramesh, because we'll be seeing more of him and his family today. and sort of recap in your mind what you have learned from yesterday. And again, I also hope that you would have a chance to go through the webinar, which is a pre-recorded one available on the website, and would have had a chance to go to the ebook, because it will greatly help you in this session if you've already had a chance to go through both these resources. So today's session in this echo, what we are hoping to cover is, hopefully you'll be able to understand about the algorithms for the common physical symptoms, which is given in the ebook. And we'll also conclude by mentioning a few of the essential medications for palliative care. And as I mentioned, this particular session is just, after the whole webinar, this is just dealing with the symptom control, and we'll be mainly dealing with the more common symptoms of agitation and breathlessness. Hopefully you would have downloaded the ebook already, and also PalliCare app is a very good app that can be used by palliative care physicians, and it's free to download. It's produced by Karunasraya, so that is also one additional tool that's quite useful in symptom management settings. Okay, coming back to Ramesh. So I hope you remember Ramesh now. So what we know now is that Ramesh has been admitted to the hospital, and Suresh, who's Ramesh's son, he calls the COVID-19 helpline and says his father has symptoms of sore throat and dry cough. So at the advice of the medical officer, it was decided to move the gentleman to the nearest COVID treatment center. Once he comes to the hospital, they have done an esophageal swab, and that's sent for testing, and it has been resulted as positive for COVID-19. So obviously Ramesh is clearly anxious. So if you remember from Ramesh's history from yesterday, we know that his son had come back from Middle East, and obviously, they are all worried about Ramesh might get the infection. So Ramesh is clearly anxious and unsettled, and he keeps asking to his family, will I ever see them again? So I would like to pause now and let you use the chat box and make it an interactive session for us to discuss what are the issues that is concerning him, Ramesh, and the family, and how are you going to respond to this issue. So what are the thoughts? What is going to Ramesh's mind? Please feel free to use the chat box, and if such questions comes, how are you as a medical person going to respond to that? Okay, so Dr. Manoj just mentioned fear of death, abandonment, very good, helplessness, guilt. Yeah. Guilt is coming up a lot.
Yeah. And Manoj has commented about loss. Could you just explain a little more, Manoj? Loss of what? Stigma from society, and does not want to be left alone. Probably from the news and the media hype, he might be knowing that he will be isolated and will be treated in a remote center where he cannot see his family members. It's very, very good. Okay, unfinished task, anticipated loss of love and family members, probably loss of role or loss of income. Finance, very good, very good. Finance. Okay. Fear of death. So now, Sunitha, we have a good list of issues coming up, starting from fear, anxiety, and then a sense of loss. Loss could be different types, like anticipatory loss, loss of closeness to the loved ones, and loss of job or probably income, and the financial issues, and death. And, like feeling isolated and stigma, boycott from the society, not only he, his family members as well, and feeling, being a highly infectious disease, so he will be thinking that he will be a cause for others to get infected. Yes, spreading to dear and near ones, contagious and debilitating, and spiritual distress, of course.
So how will you respond? So I think one of you has answered that question. So if he asks you, will I ever see them again? How are you going to respond to that? Listen to the patient concern, anticipated loss of love and family members.
And Taruna has commented, assure him that it is not necessary that it is COVID only, but might be just viral. But it is tested positive, Taruna. He's tested positive, isn't it, Sunitha?
Yeah, the swab has come back as positive. One of the doctors has asked a question whether the positive swab will give a severe acute respiratory coronavirus. No, actually, what the statement says is that he's positive for SARS-CoV-2 because that's the name of the virus. That's why it's written like that. It doesn't say that he will get severe breathlessness syndrome. He could just be COVID positive, and like when we go to symptoms, you can know the 80% actually have got mild illness. So he could just be that also.
Yeah, exactly. Yeah. Divyashree has come forward with a suggestion that assure him that we will do our best to save him.
Yeah.
And we have to be realistic and also compassionate. How will you show compassion?
So I suppose you could put it in a way by saying that we'll do our best to look after you rather than using the word save him, because if you remember from yesterday's session, Ramesh is not a good candidate if he gets a very bad COVID infection. Yeah. So we'll have to be realistic when we reassure him. Okay, so I'm just going to move on, and Raji ma'am will be looking at the chats. Yeah. So Ramesh is now admitted, and on day 2 of his admission, his conditions worsens. He's got high fever, he's got a dry cough and difficulty in breathing. He also reports feeling very tired and unwell. And the doctors do a clinical examination. You can see he's tachycardic, he's got a temperature, his pyrexial, his SATs are low, 88%, and his BP is stable. The clinical team, has a discussion, and depending on what we learned yesterday from all his previous performance status, WHO performance status, comorbidities, it's agreed that maybe it's not in the best interest to transfer him to a critical care facility. It's not recommended, and it'd be better to focus on excellent symptom control. Now, the medical officer, as expected, is worried how they're going to inform him and the family. And son has been calling and saying, please do everything for my father. So how are you going to respond to this situation? How will you handle this situation if you were the medical officer? Please feel to write in the chat.
Yeah, this could be a very common scenario because, it's true that, as Sunitha has mentioned, he's an older person with a lot of comorbidities, but for the son, he is his beloved father. So the request is quite natural. Talk with the son, Tilakeshwari comments, and how do we talk? Manage his symptoms and make him feel comfortable. Okay. COVID positive, stabilize the patient vitals, oxygen support, control anxiety. So what are we going to tell the son?
So, how to communicate to the son if it is difficult for you. So the communication session will be taken tomorrow and all the protocols will be described. But our major aim today is obviously symptom management, but you need to have in your mind your questions and the comments and the suggestions, all the sentences. So how are you going to lead the conversation? How are you going to tell the family that it's in the best interest that we look after him and keep him comfortable?
Yes, he is in the best hands.
We're trying our best. We'll do everything under control. Plan an interview with the family. So that's very, very important. So we need to have an interview, but again, remembering the fact that everybody is in quarantine and isolation. So you'll have to think of other technology, which everybody is doing now. So video conferencing, and WhatsApp video call, or whatever technology is available. If possible, do a face-to-face interview with the family.
Yeah.
Okay, and a few of you have already started mentioning the management, which we can do, which we'll discuss, oxygen and stabilizing the patient, pain management. Somebody has raised hand. Do you want to put in chat? What do you want to talk about? Or was that a mistake?
Or is it something as a response to Dr. Sheetal's comment, inform the need to start immediate management to improve quality of life, or son demands that a father be connected to ventilator? How do we proceed? So Sheetal, I think that there is, that's a point where the triage becomes very important. Sunitha has highlighted that he is not a right candidate to be put on to connected to ventilator, because it is unlikely that he will improve. Yesterday, Moira had shown the slide, how many patients will be successfully will be able to come out of ventilator successfully. So the percentage, it's, it's low compared to the percentage otherwise. It becomes a non-promising thing for an older person. So Sunitha, what do you think?
Yeah, so that's where your knowledge of algorithm, your knowledge of his best interest comes, and then it's actually having an honest conversation with the son. You could state the numbers, you could state the statistics, but you tell them, actually, even if you connect him to a ventilator with his comorbidities, the successful ventilation and him coming out of alive is actually quite minimal, the chance of him coming out alive. So that's where you communicate the figures to them. It's not because we are not doing it because it's, age is not just the criteria, it's all the comorbidities also. And also make sure you document everything. So, the trials that you've used, algorithm that you've used, make sure you have a discussion as well as document why you made that decision.
So there is a comment coming up with that, giving knowledge about the condition of the father and address to their emotions by showing them that we care and telling them that we will try our best to improve his conditions and quality of life. That's okay.
Satisfying for the family, yeah. Yeah, that's a very good, thanks for sharing that, Dr. Iqbal. So Dr. Iqbal mentioned that one patient who was having advanced cancer plus an ART with suspected COVID, I did telephonic and later video conference with his mother. It was very satisfying for the family. So it's very, thank you for sharing that, Dr. Iqbal. So it's very, very important. Even the family feels that sometimes the healthcare professionals are the people who are staying with the patient during the last hours. It's very, very important for the family to know that there is somebody with the patient even when they're dying, because they're not able to come. And it's reassuring for the family also to know that he is in good hands. Okay, so I'm going to move on. So what is different? Why is it different? Why are we having this session on palliative care in COVID-19? What is different from the other scenario? So this was this came from a blog that was published in BMJ, and it was Italian doctors who were talking about how difficult it was for them. It was an unprecedented scenario where they seem to have redefined the role of palliative care. So they're faced with an ultra emergency, but there's no relationship between the patient and the family, no typical timing also to share the information. So just like I said, it's where in the deathbed, the doctors and the nurses have to spend time with the patients. So they are behaving like the bystanders as well as the healthcare professionals. And there's an intense trauma, there's a psychological experience for the family members and the treating team. And situation keeps changing pretty quickly. So normally, as a palliative care physician, we sometimes get some time to establish a rapport with the patient and the family because things doesn't deteriorate very quickly. But COVID-19, the situation is so different that things seem to deteriorate very, very quickly. And that is why it's considered as an ultra emergency as far as palliative care is concerned. I've added some additional slides. This is not in the webinar. So in the webinar, I've only mentioned the common symptoms that's faced for patients in COVID-19. Here, I've also collected some more symptoms, which is in BMJ. So BMJ has done a good sort of online module where it's available in BMJ best practice, where they've collected evidence from all the case reports of COVID. So they've listed some uncommon symptoms also. But the thing to understand is that the uncommon symptoms are actually less than 10%. So each of these symptoms have been reported, but they're quite rare. It's less than 10%. The common symptoms are still fever, cough, dyspnea, and altered sense of taste and smell, which are the key diagnostic factors. And then there are other few common symptoms, but they're not the key symptoms like myalgia, fatigue, anorexia, chest tightness, and sore throat. Again, I won't go into details in this slide because it's also in the webinar. This is about the pathophysiology and how the the infection moves on from stage 1, stage 2, and stage 3. The only reason I'm mentioning this is that since the webinar has happened, two important things have come as far as treatment is considered. So remdesivir has got some evidence which has proven that it is cuts the recovery time, but it doesn't show any evidence in survival. And the other important thing is about dexamethasone. So since the webinar has been recorded, we've found evidence from Oxford to say that dexamethasone will reduce the death by 1/3 in ventilated patients and 1/5 in other patients receiving oxygen only. And again, I mentioned that in our talk because obviously we'll be dealing with patients who are just on oxygen. So it's worthwhile to know that even though we are not going the ventilatory route, we could start them on dexamethasone, which can help with the symptom control. But having said that, remember that if the patient doesn't need oxygen, or patient is not unwell enough to need oxygen or ventilator, then dexamethasone, if you put them on dexamethasone, they actually do bad. So it's not safe to put them on dexamethasone. So always remember that because palliative care people, we always use steroids. So that's important for us to know. But dexamethasone has got good evidence to reduce the death in ventilator patients and 1/5 of patients in oxygen only. Okay. So again, I'll just go through this one. As I mentioned before, how do the patients present? And mostly it's subclinical. They are the least serious ones. But a few patients can have symptoms of upper respiratory tract infection like fever, cough, but milder symptoms. So important thing to know is, or reassuring thing to know is 80% still have got mild illness, and only 5% will present with a critical illness. And once they reach the critical illness stage, what they've described it, the death is usually, so all those patients who are reaching the end of life or critical illness stage, they do have symptoms like high amount of breathlessness, or it's described as air hunger, high amount of distress, and this high delirium or agitation, and high fever. And sometimes death occurs pretty much quickly. So it can be either a short number of hours or very short days. But fortunately, 80% still have got mild illness. Now, coming back to Ramesh. So everyone is in agreement that Ramesh should have conservative treatment based on his comorbidities, previous performance status, and present deterioration. And the son has said, please make sure he does not suffer. You want to make sure Ramesh has the best symptom control and support, and therefore we have started him on high flow oxygen. We do further tests, and all the investigations show that X-ray shows bilateral lung infiltrates. He has raised D-dimer, leukopenia, and raised transaminases. So you are a junior doctor and you're discussing Ramesh's case with the senior colleagues. So what questions do you want to ask the seniors about Ramesh? So have you got any doubts in your mind about the route you're taking? So if so, what questions do you ask? And have you got any questions about how to make Ramesh comfortable, or do you know what you're doing? So what are the key issues in control of symptoms of breathlessness? So I would like you to think about, take a pause, think about how do you manage a patient who has got breathlessness? Just suggest all the management that you know of and you've been doing so far, and then we can discuss further.
Non-pharmacological, Pravina comments.
Yeah.
And positioning.
Positioning of the patient, good.
Prone ventilation.
Prone ventilation, good. Oxygen.
Oxygen. Okay, he's already on. Very good. Oxygen and heparin.
Well done.
Drain secretions. Very good. Prone ventilation, Rajini has come up with that query whether it's prone ventilation or prone positioning.
So I think it has to be prone positioning if we are dealing with the patients because he's not on a ventilator or Ramesh. Yeah. Prone ventilation is tried for patients who are on ventilator and it's been shown to show good results. But as far as Ramesh is concerned, we'll have to try prone positioning for him.
Okay.
Awake, prone, high flow oxygen and control anxiety.
Okay. Yeah. Deepak also has commented something to do with anxiety. Just physiotherapy?
Yeah. So I'm glad you've mentioned the non-pharmacological management of breathlessness. Can you suggest some sort of breathing techniques that you're aware of, if you're aware of any non-pharmacological? What are the non-pharmacological techniques you can use? Fan, yeah. So electric fan, I'll come to that when we're discussing it. Fan is one of the proven one that we can use for non-pharmacological.
Upright position.
Prone position. Upright position. Yeah, positioning is one.
Anything else non-pharmacological? Pursed breathing.
Yeah.
Reduce room temperature.
Yeah.
Complementary therapies.
Flower and
technique. Oh, very good, very good.
I think you know that already, or you listen to my webinar.
Great response. Yeah, correct. Stepping, sleeping in a relaxed position.
Okay.
Okay.
So you seem to, everybody seemed to have a general idea of what we are doing. What about pharmacological management? Anything else other than the things that we have discussed? Cool temperature, cooling the face.
Cooling the face. Applying wet towel. Anything to go pharmacological? Suggestions, please.
Morphine, yeah. Thank you, Manoj.
Yeah.
Morphine, okay.
Yeah.
Paracetamol for fever, good.
Yeah. Morphine.
Yes. Thank you. Okay. Yeah.
Just wondering about morphine. Okay.
Heparin, yeah, D-dimer is raised, and not only, yeah, I think D-dimer levels are quite high, and even then, I think I recently read an article by one of the doctors who's done the PM's postmortems of lots of COVID patients, and apparently almost all the organs have got clots in them. So there is a hypercoagulable state is very, very common. So yeah, heparin is important. Fentanyl, PCM, low mercury heparin, oxygen, fentanyl.
If able to swallow, nebulizer mask. A lot of people are coming with suggestion of morphine.
Many non-palliative care doctors say morphine should not be used. Okay, I think that's a good question, and I'm glad Dr. Iqbal brought it up. I need to discuss that. Yeah, low-dose morphine and benzodiazepine. And so, yeah, I'm going to move on.
Okay.
So it's important to understand when we think about managing breathlessness in COVID-19 or breathlessness any other situation, especially in COVID-19, it's important to understand why it's so difficult. So if you know the complex pathophysiology, there's a cytokine storm, there's a hyperinflammatory stage, and lots happening in the lungs. It can be either consolidation, it can be pleural effusion, there's microthrombi formation, and there's PE happening. So lots of reasons for the patient in the lungs to be breathless. On top of that, there's additional vulnerability because the patient's age is advancing. We know he's got comorbidities, and his trajectory he can become worse. Patient has got lots of anxiety and worry, a lot of information, social media, so he's anxious, and again he's going to be in isolation ward. There can be psychosocial effects like guilt and fear. So when we try and manage the breathlessness in COVID-19, we need to think of all these things, not just the lungs alone. And that's why it's it's very, very important to understand the pathophysiology and the management, of breathlessness. Again, we've already discussed all this. Always follow the management protocols. And the thing to remember, understand about the ebook or this entire resource toolkit is that we are not saying, or whatever we are saying, actually the management goes side by side along with the active COVID management. So you have to follow the COVID protocol. And once we know that he's not getting any active treatment, or you can still give all these management side by side for the patient for symptom management alongside the active protocol. So correct the correctables. If you've mentioned a few, you have to give antibiotics for superadded infections. So antibiotics, if you give it, it can help with breathlessness. So fever, cough, and breathlessness, antibiotics can help. His comorbidities, don't forget that. So if he's got COPD, nebulizers for that, heart failure. So don't forget a furosemide. Even there's lots of fluid overload here also. So don't forget the diuretics. We can give that. Cough and breathlessness, and all these. So once we do all these managements, once all the medical management is being done, and still the patient is breathless, so we have given the term of refractory breathlessness in our ebook, and that is a breathlessness that is not improved despite optimal medical management, and that's when we go into all the algorithms that we have suggested. So again, we have mentioned all these things, all the non-pharmacological techniques of positionings, oxygen, high flow oxygen, it's needed for our patient. The few of the exercises, a few of the breathing that you could try is actually relaxed tummy breathing, breathe a rectangle, recovery breathing, and calming hand technique. Now, I won't go into details of all that in this session because that as such has to be taken as a separate session, but there are lots of breathing techniques and exercises you can teach the patient when he's well enough to learn that, so that it can be tried in this situation. Then other than the prone ventilation is good for as far as COVID is concerned, but prone positioning, but for the breathlessness positioning, what we normally suggest is the position that gives the maximum comfort for the patient. So it can be sitting upright, legs uncrossed, or shoulders drooping down, head up, and lean forward. Other relaxation techniques, again, chest physiotherapists, respiratory physiotherapists or nurse practitioners can come and teach the patient. Other relaxation techniques can be tried. And you have also mentioned about cooling the face. So about handheld fan. So handheld fan is an important non-pharmacological technique which has been practiced in palliative care. The only problem with COVID is that any sort of aerosol generating procedure, so nebulizers and handheld fan, is currently not been advised, especially in a healthcare setting. If the patient has been managed at home in situations, if that's been happening, then the patients are allowed to do that. But in healthcare setting, because of the risk of infection, we don't advise that. But we say cooling the face with cold towel can be used, or cool in the room can be used. So these are the non-pharmacological techniques that can be tried. Now, I'll just mention the dosages and just to mention briefly about the medication that we have suggested. So if you've already gone to the algorithm or the ebook, you'd see that we've divided it into mild to moderate breathlessness and then severe breathlessness. And we have suggested morphine. So few of you have already mentioned morphine and also benzodiazepines. And this is what we have also suggested. And all the doses, it's just a suggested doses, which can be changed according to your patient need. Now, I'm sure lots of you are familiar with the use of morphine, but for the ones who haven't used morphine for breathlessness, I just want to mention a few lines about morphine. The reason why we use morphine for breathlessness, it's been proven that morphine can be used for breathlessness, even for COPD patients. And that's because we know that morphine reduces the hyperventilatory response to hypercapnia. So the respiratory rate comes down and the work of breathing comes down. In addition, morphine also causes pulmonary vasodilatation. Also it's an analgesic, so it's used for pain, and as pain settles, the breathlessness also can get better. And also it depresses it causes sedation of the cortical centers. So thereby the feeling of breathlessness is reduced in the patients. And this has also been proved in a randomized controlled trial in COPD patients. So that's why morphine is now proved to be of use in breathlessness. And we suggest both the doses of morphine as well as fentanyl in our ebook, depending on the availability. So in the next page, I'll go to the algorithm. And again, I'm not sure how clear this is, but this is given in page 14 of the ebook. So we have suggested this algorithm, and we have divided the refractory breathlessness depending on where the patient is. So we have given patient in ICU and patient in ward, and we've given suggestions for both non-pharmacological and pharmacological management. And non-pharmacological management we've already discussed. In pharmacological management, for patients in ICU, we have given dosage of morphine, as well as we give dosage for fentanyl, depending on the availability. Like some places fentanyl is available, and some places morphine is available. So depending on that, you can do that. You can give fentanyl in ward also, but again, it depends on how comfortable the nurses are in doing that. So that's why for the patient in the ward, we haven't suggested fentanyl. We have suggested dose of morphine. And the last box, significant respiratory distress or respiratory rate at more than 30 at end of life. Now, the important thing to notice is, and again, I would like you to put your answers in chat. We've given dose both oral morphine and subcut and IV doses. And the subcut doses, what we have suggested is either bolus doses of every 2 hourly, and or if there is available to start an continuous infusion, you can start a continuous infusion with morphine in a syringe pump or as an infuser, if that availability is there. Also, if the patient is anxious and agitated, you can give midazolam, again subcut doses and IV doses we have suggested every 4 hourly, or if the patient is able to solo, you can give lorazepam, again depending on availability. And if options of continuous infusion are available, so I'd like to put on chat how many of you are familiar with the use of continuous infusion palliative care and the usage of both these drugs to manage pain and breathlessness. And with the subcut route also, if you're familiar with that or are happy with using that. A fentanyl dosage, again, we have suggested is 100 microgram as a 24-hour subcut or IV infusion, or bolus doses is 25 microgram IV or subcut 2 hourly is a dose that we suggested. Now, I noticed in one of the chats somebody has mentioned fentanyl patch. Now, I don't think patch is a good idea in this situation, because patch usually takes some time to start working. So patch, as we all know, is a transdermal preparation where the medications absorb through the skin. And when we first start using the patch, it takes at least 12 to 24 hours for this patch first to start working. So one thing you could do is you could start them on infusion of fentanyl first and then convert them to a patch. So put a patch additionally on, and then you titrate the infusion gently and then change that to a patch. Otherwise, putting them straight away on a patch might not be, it won't work properly because it will take some time to start working. You need some boluses on the same time. So anything has come in the chat?
Yeah. Rajini has commented on one important feature here is all measures for breathlessness relief in a patient who is not going for mechanical ventilation can be done in ward itself. That's a very important comment.
Yeah.
And therefore worsening clinical condition is not an indication to change location of care when palliative care goals of discussion have been done. That's a very important point.
Yeah.
And if they're bronchospasm, bronchodilators, not nebulization. Yes. Iqbal, I think he was commenting about nebulization because nebulization, as you have mentioned, Sunitha, it is aerosol generating procedure. It could initiate a droplet transmission. So better we avoid that. And in that case, we may use bronchodilators. That is what Iqbal has mentioned. Can we use morphine in a patient with relatively low SpO2 if saturation is around 75 to 80? That is what Deepak asks. Rajini has commented.
Yeah, definitely. I think
IV steroids.
IV steroids
Okay,
also
Sunitha.
bronchospasm. Yeah. So Deepak, we don't look at saturations when we use morphine. So we use morphine mainly for the symptom of breathlessness, so that patient doesn't, appreciate, or a patient doesn't feel breathless. So normally, I wouldn't worry about saturations. Obviously, we give oxygen on top of that, but hypoxia is not a contraindication of not using morphine. Okay, I don't think somebody has mentioned about Dr. Divyasri has mentioned that she hasn't used subcut route of administration of drug, and nobody else is commented. So I'm hoping that everybody is familiar with this. And steroid should be used if there is hypoxia. Yeah. So just like as I mentioned, on oxygen patients, dexamethasone is it should be given, and it's proved to help them with the mortality also, to preventing mortality.
Okay.
Okay. So that's our algorithm and on breathlessness. Coming back to Ramesh. So Ramesh has been stable for a day or two, and then staff is noticing that he's becoming agitated. He's mumbling incoherently. He's trying to remove his mask. The nurse is looking after him, feels that he's frightened. So what do you think is happening now? What do you feel is the cause of his symptoms now? So his breathlessness is settled, but he's becoming more agitated. And how will you assess and manage his new problem? So what's happening now? Please put in chat.
Delirium, anxiety.
Yeah.
Yeah, delirium. Okay, more vote for delirium. Okay, anxiety.
So if you think of delirium, what could be happening here? Why do you think he's becoming delirious? So it can be bursting dyspnea, yeah. Breathlessness with anxiety. Anything else? So what do you think of patients who are going delirium? What else can be the cause?
Agitation and isolation. Okay.
Yeah, so that's very, very important. So
hypoxic encephalopathy.
Yeah.
Possible.
So isolation is again very, very important. We all have heard of ICU psychosis, where patient is in ICU and can't see anybody, and that's why we think ICU psychosis. But here, the patient is not in ICU; he's in ward, but he can't see anybody, isn't it? He's completely separated from the family. So that could be a cause of that. Hello, sorry.
Sunitha, Nancy has raised her hands. I mean, Nancy, want to say something?
Yeah.
Was it by mistake? Nancy, please, if you want to comment anything, do you want to speak?
Yeah, persistent hypoxemia, hypercapnia. One of the doctors have asked whether it could be the effect of morphine.
Could be due to effect of morphine.
Yeah, and which is a very important point. It could be that because if it's an opioid naive patient and you put him on morphine, there is a chance that it can cause delirium. But again, what we do is we bring the dose down back and see whether he gets better. But yeah, sleep deprivation. Yeah.
Dehydration, another point. Non-ambulatory status, reduced physical activity.
Okay. Yeah, please keep writing in chat. So this is one of the posts I found in one of the Facebook pages of COVID-19 palliative care providers. And I think this probably was from US, and they've mentioned about seeing horrendous delirium from COVID, and nothing seems to be touching it. And apparently whatever medication that we normally use for delirium doesn't seem to be working for them. And one of the doctors have mentioned is that it's a mixed bag of hypo and hyperactive delirium. Extensive medical workup was done, and all the other reversible causes was removed, and they've termed it. They've given a term of COVID and encephalopathy also, and they've given other things like aggressive bowel regimen and getting hearing aids and make sure that it is working, getting translators in, and sometimes drugs were not touching that. Now, having said this, I had a chat. I had a Zoom call with one of the our colleagues in UK, and they presented their scenario in their hospital, where actually they haven't seen much of delirium. So the main symptoms of patients who were dying were fever and breathlessness. So again, COVID is presenting in different way in different places now. So they didn't have to use higher dose of any of the drugs. They only used some midazolam for breathlessness rather than for any agitation. So that was quite interesting. And this again came from the British Geriatric Society, where they've given a poster to describe the atypical presentation of COVID-19 older adult. Now, if you remember from the symptom slide I presented, the uncommon symptom was a neurological symptom. But apparently in elderly population, this is what UK had seen. So how does an older adult can present, and they've asked to watch out for delirium, anorexia, fatigue, malaise, false syncope, and actually the patient may not even present with cough, dyspnea, or temperature. And this is what they saw in their elderly adults in the UK. And subsequently, they brought out this poster for older adults for COVID-19. So delirium is a very important presentation for elderly, again, in the UK. Now, we have mentioned this 480 assessment tool in the ebook. Now, again, this can only be used depending on the scenario. There are various tools to assess delirium. This is the simplest one that's available, and where you have to score on alertness. You use AMT4, where you ask the patient about the age, date of birth, name of the hospital, and the current year, and you have to look for attention and also for acute or fluctuating change in the conscious level. And if they make 2 or more mistakes, they are for AMT, they are either untestable or given a score of 2. And for each category, we give a score. And if the total score is 4 or above, then there's a possibility of delirium. Again, we don't know how much you're able to do this patient. Probably, Ramesh, you probably might get a time to assess that and to actually find out whether he's got delirium or not. And the reason we have given this, or reason is important for us to know delirium, is because the management that we have suggested has got a slight difference depending on the fact that he has got delirium or not. Okay, and all the management in the ebook is again based on NICE guidelines and Center to Advance Palliative Care guidelines, and they've all suggested checking for other causes of delirium. So you have to manage other symptoms. So again, breathlessness and pain, we mentioned that, but on top of that, he can be in urinary retention, he can be constipated, so you have to manage that as appropriately. There could also be withdrawal syndrome, so people can be having alcohol withdrawal, or even usually in the initial days of lockdown, we had lots of people with alcohol withdrawal, or even in narcotics like morphine or tramadol, if they're already taking some pain medications and they could be withdrawing because of that. So you have to think of all these things and to correct that, and then move on to think about the delirium of COVID-19. Again, coming to the another algorithm, just given in algorithm 3, which is given in page 17 of the ebook. So this is a reason we mentioned about the AMT4 criteria, is mainly because we've divided the agitation into agitated patient and disoriented patient, that is delirium, and agitated patient without any disorientation patient, where we've given the guidelines to manage as anxiety, panic, or fear. So if the patient is delirious, the first line medication we have suggested is haloperidol. And again, you could try, the doses also has been given. We've given IV and subcut routes, and even peroral doses have been suggested. And we've divided that into mild and moderate, and then intractable or severe symptoms. So if the patient doesn't set, if it's got delirium, we start with haloperidol, and the symptoms doesn't settle, the patient goes to moderate delirium. We have suggested to add midazolam. Again, you can give us a bolus injection, or you can give us a continuous infusion, depending on the availability. Now, if the patient doesn't have any delirious symptom, but is very, very anxious and is panicking, so panic attacks are coming, he's agitated, but he's quite oriented, then the first line that we've suggested is a benzodiazepine. So you can either give lorazepam or clonazepam if the patient is able to take it by mouth, or you can give midazolam. Now, if the patient doesn't settle with the benzodiazepine, and then it moves on to moderate agitation, then we suggested adding haloperidol to that. Now, if the patient has got intractable or severe symptoms, which is not settling with any of the above measures, the dose that we've suggested is to give a combined infusion, either IV or subcut, of total dose of haloperidol 20 milligram or midazolam 30 milligram can be given as a continuous infusion. The thing to remember is in palliative care, and those who are familiar with palliative care might know this, all the infusions usually we give as a subcut route, because subcutaneous route is less traumatic. We can even do it at home. It's not painful for the patient, and that's the reason we go for that. And sometimes IV access is quite poor in the patients who are dying. So we suggest subcut route. And also to control the symptoms like continuously around the clock, rather than giving bolus injections, we always ask for a continuous infusion. So, and all the medications that we use in palliative care are compatible and can be mixed together. So suppose Ramesh has got a very bad complex of symptoms of severe agitation and breathlessness, he can be given a continuous infusion of morphine, midazolam, and haloperidol over 24 hours, and the total dose can be mixed together, mixed with normal saline, and the infusion can be given in a syringe pump or an infuser pump over 24 hours continuously. So is there anything else in the chat, ma'am, that you need to add?
Yeah, Sunitha, one person has, I think Pravina has asked whether how to differentiate delirium from hallucinations. Am I not audible?
So hallucination is a symptom. Yeah, hallucination is a symptom in delirium.
Yeah.
So patient can be seeing things that's not. So that's one of those questions we ask him, ask the of the patient, and so hallucination could be because he's delirious. That's why he's hallucinating. Yeah, yeah, ma'am has mentioned that. Yeah, for global cerebral dysfunction. Yeah. Okay. So just again, other few symptoms that we have mentioned, and again, this is in the ebook. This is those who are familiar with PalliCovid will know, and all the others would know that we go with the WHO's step ladders to manage pain. It's not different from what you already know. They divide into mild, moderate, and severe. And for mild pain, we have suggested the paracetamol dosage. And again, moderate, we can give tramadol, that's weak opioid, and severe pain, we go for morphine. Here we have suggested both the transdermal fentanyl patches and the oral morphine. And depending on the type of pain, we can give adjuvants and also provide psychosocial spiritual support. You can use NSAIDs. There was a controversy about NSAID in the initial months of COVID, but that has been cleared. So NSAIDs can be used. There's a definite indication for its use in COVID. I'll conclude by mentioning the essential medications. So this is again in the page 62 and 63 of the ebook. This is adapted from the IHPC and WHO list. And these are the list of essential medications that anybody with the palliative care practice, any country should be able to provide. And they're simple medications, again, which covers most of the symptoms of palliative care. And the ones that is in bold are mentioned in the ebook. That's why it's given differently. So some of the, again, depending on which country you're from, like some of the medications are not available for us, like for levomepramycin that is mentioned here, number 15. It's a very good drug for, nausea and vomiting and agitation and terminal, but it's not available in India, so we don't have that. Then again, oxycodone, it's a strong opioid, moderate to severe pain, synthetic opioid, not available in India. So there are lots of medications that we still don't have, but this is a suggested list that WHO and IHPC put together for palliative care symptoms. So to conclude, it's important for us to recognize a symptom complex of breathlessness and agitation in a severe COVID-19 pneumonia, and opioids should be made available. So when we rush around to look for all the medications of COVID-19, make sure you get some opioids also to manage this patient, because it is needed. I read, I was seeing a video of one of the nurses, I think in Malayalam, was telling about asking us to, make sure you stay indoors, because we are tired of seeing patients dying of breathlessness. This is what they were telling. And so it's so important, isn't it? Because we know that some people don't get better and they are going to die. And we don't want them to die suffering with breathlessness. And it's a simple thing like in an opioid. It's not simple. If it's available, it's simple. But if it's not available, it's not simple. I know that. But people should be thinking about that. And even the healthcare workers who see such patients dying and the trauma it's causing to them, they don't want to see patients suffering and dying of breathlessness. And if opioids are made available to them, you should give them. We should make sure they get them so that patients are comfortable in their last hours. So 480 delirium assessment tool is quick to use. Remember to assess and rule out and manage other causes of delirium. If anxiety and restlessness without disorientation, we have suggested a benzodiazepine. And if there is disorientation, you start an antipsychotic. I think I've come to the end of the session. the last few slides suggest thank you for all the people who have contributed, and actually I'm so happy that we have reached here. We started our first session. We started the work in March of the ebook, and Moira must have told you yesterday that we have reached we've reached out to a lot of people, and I'm so glad that we could do that. Thank you, PalliMinty, for taking it forward and doing all the pain of inviting people, and and thank you to all for contributing.
Sunitha, there is a question in the chat why azithromycin is not presented as an essential drug. Why it is not?
That's an interesting question, because I think azithromycin is an essential drug for COVID-19 for the antibiotic, but I don't think any antibiotics are there in the list. This is a list of palliative additional medications that is prepared by WHO and IAHPC. I'm sure antibiotics are important, but I don't think that is there in the list. So it is not a COVID-19 specific list. It is a palliative care specific list. But azithromycin should be given and to prevent a secondary bacterial infection.
So friends, Sunitha has taken Ramesh with us. Yesterday, he was in a different setting, like with lot of comorbidities and problems associated with an older person. So today, unfortunately, he was tested positive for SARS-CoV-2. So we have found him so sensitive and anxious to begin with. I mean, will I be able to meet my family members? And then we have seen his son coming and asking the professional caregivers that do everything what is possible for my father. Then we have also seen them, finally compromising to do what is best for Ramesh and to provide optimum symptom care and to best quality of care. So Sunitha has taken us towards how symptoms can be managed, both pharmacological and non-pharmacological measures, by keeping touch. Along with that, keeping touch with Ramesh, close family members, how communication is important, how regular family meeting is important, how we have to finally blend non-pharmacological and appropriate pharmacological measures together so as to provide appropriate symptom control and then quality of life. And finally, the golden message she had delivered is, while getting the symptoms control, we should not lose the humanitarian touch of palliative care, because that's the most needed in the challenging scenario, as yesterday Moira had rightly pointed out. So thank you, Sunitha, for that wonderful session, and thank you all participants for their brilliant suggestions. I am so glad to see that many people had gone through the webinars and the toolkit, and they have come forward with suggestions for morphine in the management of breathlessness. For us, it is such a heartening experience to see that morphine in the list for providing symptom relief for breathlessness. So thank you, friends. So anything else?
There's a few comments in I think we've got some more time left. So one of the doctors have asked, few scholars prove symptomatic relief in COVID-19 with alternative medications like Ayurveda. Please discuss. I don't have any experience about that. I mean, there's lots of, I think that even our government was saying that you could increase immunity and prevent COVID-19, and there was discussion about giving, I've heard discussions about giving homeo medicines and Ayush involved. But I don't know about, what sort of alternative medications they have suggested. I would ask one of the other faculty to answer, probably Dr. Rajani. There's one more question that I would like Dr. Rajani to answer. So, ma'am, since in some states we have bereft supply of ventilators, and I wanted to know when it's very essential to ventilate a patient. The question might be very simple one for the doctors, but I'm a doctor, not a doctor, and want to know this. So, if Dr. Rajani is in the call, do you mind chipping in and answering that? Dr. Rajani is a pulmonologist with a special interest in palliative care, and it's now on the extended faculty of PalliCovid Kerala. She's still there.
Madam, please come forward with your suggestions and inputs for bringing in more appropriate symptom control and thereby quality.
I think Dr. Rajani is not on the call now.
I am on the call.
Oh,
I got unmuted. I was muted and it was out of control. Sorry. Hello. So I'm so sorry. I just if I could just get that question again about, was it about availability of ventilators? Was that?
Yeah. So it's questions about when it is very essential to ventilate a patient.
When is it
So,
very essential to?
criteria to
Okay.
go into ventilation.
So, for example, if we're looking at a patient who does not have the issues that were concerning us with Mr. Ramesh, which is that we were looking at the point of ventilation being a beneficial versus a non-beneficial treatment. We were looking at it from the point of view of even amongst patients who are ventilated with severe COVID, the recovery rate, I know that one of the JAMA studies said it was 88% people did not survive. That's not really true, because if we actually look at the analysis of all the patients in that, it comes to something more like 30% recovery, but again, with a very prolonged course of recovery after that. So the patients who have been given, see, earlier we were doing early intubation and ventilation because we were thinking of trying to decrease the contagion, because we were worried about using high flow nasal cannula or NIV. Now, in the intensive care unit with very good PPE protection, we do give high flow nasal cannula and NIV trials. And it's again back to the same good critical care at the bedside. So if a patient has all the features where we do the standard critical care scoring with an Apache scores and SOFA scores, and you think this patient is going to recover, you can go ahead and ventilate in the same way that you would for any other viral pneumonia. So if it was H1N1 or any other severe pneumonia, ARDS, ALI progressing to ARDS, you would give a trial of high flow oxygen or NIV, not getting better. Based on your clinical judgment, you would ventilate. In COVID pneumonia, we have seen that there is a spectrum. Some patients have very compliant lungs and some do not have compliant lungs. So again, it's a bedside decision. Prone positioning, prone ventilation is recommended. Whether you will use low tidal volume, high PEEP versus standard tidal volume and standard PEEP will depend on the bedside measurements of airway pressures. So that's the specific part of ventilation for COVID pneumonia, severe COVID pneumonia. So nothing different from your standard ICU care. I think fundamentally what we realized in 6 months is that all the clinical judgment calls of 20 years of critical care still hold true. Except for the fact that the survival and mortality benefit with ventilation and COVID pneumonia is a little less than with standard bacterial pneumonias and viral pneumonias that we've dealt with so far. So the need to evaluate for non-beneficial treatment and avoid that is far greater here.
Okay, thanks, Dr. Rajni. One more thing I'd like to say before I conclude is if any of you have got have questions related to opioid access or how to get hold of morphine, if you could contact PalliCovid India and they will help you with that. So, you could email them or contact them straight away. Over to you, Rajlakshmi and Smriti.
I think, hi, thank you so much. I think Dr. Sheetal Raj had put her hand up. So, Sheetal, would you like to say something?
Smriti, I just had a doubt. Can I ask?
Please.
Yeah. I just wanted to ask that regarding the treatment modalities that we discussed for management of dyspnea or the mild moderate part, which you said was in the ward. If there is a patient who is not triaged into fully palliative care, meaning we are still doing some disease-directed therapy, and the patient is on, say, some kind of a support, oxygen or HFNC or NIV, and is maintaining a fair degree of oxygenation, which is sufficient for us to not escalate care. At that stage, the patient still appears to be in some degree of distress. I'm just telling you the experience I have had in my ICU. So the degree of distress, would you advocate that we give morphine to such a patient? Because I get a lot of opposition from other clinicians who say that
yes, absolutely.
Morphine here.
Yeah, we can give morphine. So low dose morphine, trials have been done for COPD patients, and it works. And I personally, we do it all the time. I had a patient who was on NIV on ICU, and was very, very in Kerala, not even UK, Kerala. He was very, very dyspneic, and you couldn't control his breathlessness. We started him on low dose morphine, and actually it helped his breathlessness, and they were able to take his NIV off, and his breathlessness improved because of the dyspnea. So I think you can still give that. That's why we say all these suggestions is actually alongside the active treatment.
And does this hold good even for benzodiazepines? Because there is a lot of resistance from physicians regarding this.
I would start with morphine first line. So normally, even palliative care, what we suggest is that the patient is having very, very bad anxiety attacks and panic attacks because of breathlessness. Then is the time when we go for benzodiazepine. So start with morphine first line and see. But if patients very, very anxious and agitated, you can give benzodiazepine low dose also. Again, I've been putting palliative care patients on diazepam down the clock, and they've been going home, managing at home, not feeling breathless, but on benzodiazepine. So it is given.
Thank you very much.
Sunitha, we have a few, I understand we have few pediatricians as well in the group. Do they have some suggestions? Am I audible?
Yeah, if there's
yes, ma'am.
Pediatricians, you could say about if you've seen, either COVID-19 patients, kids, please let us know about that. That would be really useful for us.
Sunitha, what we understand is the disease trajectory runs, it doesn't run so bad as in adult, in children, no? It takes a milder course, I think.
I think it takes
because of multiple reasons. Maybe the cytokine storm, it is much less. And then the children, they don't have that kind of comorbidities as adults have. So, the disease trajectory, it runs a milder course. So pediatricians, please come forward with your experience. And
the doctor has mentioned, we have seen COVID-19 patients in children, but incidental findings.
Incidental finding, okay.
Father
complaints, okay. Good.
Okay. Over to you, Smriti, then. Thank you.
Thank you. I'm just waiting to hear from Moira. I'm just going to unmute Moira there. Moira has something to share. One moment. Arun, just check.
Sure, I was just going to, greetings everyone. I've been following the chat, very interestingly and fascinating session. Well done, Dr. Raji and Sunitha. I was just going to agree with what you were saying, that COVID is being seen in children, but not usually in an end stage way. But there are these unusual but documented Kawasaki type inflammatory changes. I was also just going to emphasize that opiates are safe in children. We just adjust the doses. There are management guidelines that are used in many settings. I think I mentioned International Children's Palliative Care Network. So these are also safe medications to use at the right time in children. But we're not seeing this as such an issue in COVID-19. Thank you so much.